All right, welcome back. Gonna ask us to come back together. Hopefully you got a little nice extra bonus short break. Thank you. All right, we have officially located all humans that are on this panel, virtual and otherwise. So we are ready to get started. Thank you again, everyone, for being here. We are just so thrilled to be able to give a collaborative panel about piloting a plan of safe care framework for Colorado, accelerating progress and aligning investments. As was introduced, my name is Courtney Everson. You'll hear more about me and my role in a minute, as well as my colleagues here at the front of the room, and two of them that will be on Zoom momentarily. So as we get into today's time, this plenary really has an objective of sharing early learnings from an innovative pilot on a community-led infrastructure for plans of safe care. As I sat through this morning's sessions, over and over again, I heard the need to break down silos, to celebrate the progress that we've made, and find ways to do better, and to really think about what it looks like to continue to garner data in both numbers and in narratives and in stories that help us to think about approaches that move upstream in family support and maximize our investments so that when there can be a question on the table of what do you need, we're ready to answer that in a really meaningful fashion. We also know that for many of you, and I think this was very well underscored at the beginning of our day with opening remarks by Dr. Wong of what does it look like to acknowledge the birth hospitalization as an event with real potential? And how do we improve care transitions not only after that event, but also before that event? And much of what we're going to speak to today is thinking about that upstream approach, opportunities to leverage community-based approaches, and opportunities to think about prevention from prenatal forward. So we're going to start here in just a moment with panel introductions, and then we're going to really anchor in the what, why, and how of the Plan of Safe Care pilot. You're also going to learn more plans of safe care. Much of this room is familiar, but we are going to start with some level setting around this because our goal is not only to think about plans of safe care as a tool for care coordination, but as a real leverage point to be reducing the fear and stigma that comes with involvement in child welfare and the threat of child welfare involvement. And how do we use it as an opportunity to divert families from child welfare whenever safely appropriate to do so? And how do we improve those collaborations necessary to make that ideal a reality? So with that, the Plan of Safe Care pilot that we are going to be talking about today is being done in the San Luis Valley, which is our geographic catchment area. And so we have representatives today from our San Luis Valley local area partners. And this is really intentional because the Plan of Safe Care pilot is a collaborative endeavor between the Colorado Lab, Illuminate Colorado, the Kemp Center, and Dr. Kathy Wells and Dr. Becky Orsi are here in the audience with us, and resourced by the Division of Child Welfare here in our Colorado Department of Human Services. And we can't do it as a pilot team without our local partners. And so the collaborative panel that we have here today brings together implementation partners, lived expertise, healthcare perspectives, data perspectives, because we're aiming to model the very collaboration that is going to be essential if we are to have success in plans of safe care efforts that really begin to center families and communities, not just our systems. So with that, I will go ahead and kick off our panel introductions. I'm going to ask everybody to say their name, their organization, and a sentence or two about their role in this pilot work. So Courtney, still with the Colorado Lab from 5 minutes ago. And our role in this pilot is really twofold. We're really bookending this with data-informed perspectives on how we can approach plans of safe care differently in the state. And so much of our early learnings from a statewide perinatal substance use data linkage project that linked together birth and death records from vital records with child welfare records really allowed us to identify some pretty specific data points that made the case for moving upstream in plans of safe care and opportunities to improve care coordination. So we continue to take those data points as well as narratives from families through qualitative research to really help outline what this pilot opportunity might look like. On the back end of that, Not surprisingly, we're helping to lead the evidence building for this project, so we find out what works for whom and under what conditions, with the goal of being able to adapt it to local communities that you serve, and the goal of being able to say, how do we really accelerate progress in this state? So with that, I'm going to hand it next to my two colleagues here up front. Katrina, would you like to reintroduce yourself, this time more specifically about your role in this pilot?
Hello, my name is Katrina Baker, and I work with SLV AHEC. And my role in this pilot is to basically gather data and go out and get to my peers and see who needs the help. Get out there and break the stigma with them and break the stigma with the community in the area.
Hello, everyone. My name is Jade Woodard. I am the Executive Director of Illuminate Colorado. Illuminate is a statewide nonprofit focused on strengthening families, organizations, and communities to prevent child maltreatment. I have the privilege of co-chairing Support Colorado with Dr. Wells. You heard a little bit about this morning. And my role in this pilot is really, Illuminate serves as the catchment area intermediary. So we are doing a lot of the coordination work, kind of connecting the framework, the training, the evidence building with our partners in the local community and ensuring that they have the resources that they need in order to do this work locally.
Thank you. We'll go to our Zoom panel participants as well. I will ask Audrey for you to introduce yourself next.
Hi, everybody. My name is Audrey Rich Loy. I'm with San Luis Valley Health in the San Luis Valley, and I oversee all of our initiatives related to population health management and transitions of care, which this project fits perfectly within. And then I also oversee grant management. So it's the best of both worlds coming together.
Excellent. And Dr. Robertson.
Hi, I'm Dr. Amy Robertson. I'm the medical director of perinatal at San Luis Valley Health. I'm an OBGYN by training and full-time employed here in the San Luis Valley.
Excellent. Thank you so much, panel. You're going to hear from more about the perspectives and experiences that each of these panel members bring to this pilot that really helps us to think differently about plan of safe care approaches. And that's really where I want to take us next. In the spirit of keeping today actionable, and I think it was said very well at the beginning of our time, of how do we think at the systems level, but how do we also think at the local level? We want to begin to ground in what we call the golden circle, which might sound familiar to many of you. It comes from a famous TED Talk that really reminds us that change makers, all of you, great leaders, all of you, think, act, and communicate from the inside out. So the Plan of Safe Care pilot in the San Luis Valley didn't start with a what question. It wasn't what will this pilot be? It started with a data, family voice, and community inquiry into why we need to expand our thinking about plans of safe care and take a different approach. So to this end, you're going to hear about each of those components in the next little bit of time. And I'm going ahead and turn it over to you, Jade, to give us a few slides on what is a plan of safe care to make sure we have a shared mental model here in our space.
Thank you, Courtney. So we're going to start with what does federal law say? And I know this is nobody's favorite part of the presentation where I share federal law. And essentially, a plan of safe care comes from the federal requirement of state child welfare agencies. And so CAPTA, Child Abuse Prevention Treatment Act, says state child welfare agencies must have either a state law or a state program that includes policies and procedures to address the needs of infants born and identified as affected by prenatal substance exposure, including a requirement that healthcare providers involved in the delivery or care of such infants notify the Child Protective Services system of such occurrence. I'm going to call out a couple of things in this. So first is born and identified as affected by. That's kind of big language that I know is complicated for us to figure out what that means. Healthcare providers are required to notify. Notify, what does that mean? In Colorado, we do not have a process currently to separate notification of the occurrence of a prenatal exposure from a report of child abuse or neglect. So that is a challenge. Sorry, I'm previewing later, but I just want to kind of call that out, that is a complicating factor here. In addition, then, CAPTA says child welfare must have a procedure that includes the development of a plan of safe care to ensure the safety and well-being of such infant following release from the care of healthcare providers that addresses the needs of the infant and the family or caregiver, including provided referrals to and delivery of appropriate services. So this is what federal law says we must be doing in our state, that child welfare must make sure we are doing within our state. However, what the state is then required to report are these numbers at the bottom. Number of infants affected by prenatal exposure, number that got a plan of safe care, and the number of those plans of safe care that included referrals for appropriate services. So this is very much a kind of compliance-driven piece, right? This is what federal government says states must do. And so here in Colorado, we're trying to figure out how do we do this? And these pieces of law here, I think in 2016, the CARA Act was when this reporting requirement was added. So in fact, this language around plans of safe care, the identification notification plan of safe care, has been in federal law since 2003. But in 2016, when they added these reporting requirements, that's when states really got serious around how are we doing this, because now we have to report on it. So we are really lucky that through Support Colorado, we have been talking about this for years. We've been talking about it since 2008, at least. Dr. Wells, probably since 2003, when it was added to CAPTA. And so we really came together and said, we don't want a plan of safe care that is just a compliance-driven child welfare-based measure. We want to figure out how plans of safe care in Colorado can be more than this. And Courtney said it earlier, it's about care coordination. It's about a strategic leverage point to support families in beginning that recovery journey that our speaker covered this morning. It's really about an opportunity point to differently engage with and support families and offer that support that Katrina shared this morning was actually all she ever needed, was someone who said, hey, what do you need? How can I help you? So that's what we want to be different in Colorado. This is our Colorado law, still pretty similar to the federal law because that's what we do is we essentially took federal law and applied it here. So this is a collaborative process to create a documented plan for the health, safety, and well-being of an infant following their release from the healthcare provider that addresses the health support and substance use needs of the family and the infant. And again, what we're trying to do with this pilot is make it more than a compliance-driven measure, make it something meaningful for families. So I think I am going to pause there and hand it back to Courtney for our first question.
Thank you. So now that we have a shared understanding of plans of safe care, you can see pretty quickly how it can either be exactly that, a documented plan, compliance only, or a plan for care coordination that can actually move a family forward. So we are going to start with some real talk. This isn't sunshine and rainbows, right? Sounds like a nice ideal. Been working on it a long time. It's hard. And so we would like to start with a panel question of what challenges really get in the way of using plans of safe care to serve families experiencing prenatal substance use. And I'm going to kick us off on this one with a couple of data points that we know from Colorado specific data among these families. We know that plans of safe care are primarily being done at the point of the birth hospitalization, if at all. We know that for child welfare involved dyads, we have a rate of only about 39% of infants having a documented plan of safe care. We know that there are clear risk and protective factors for whether or not a family experiencing prenatal substance use becomes involved in child welfare. We know things like inadequate prenatal care is a clear risk factor for involvement in child welfare, thanks to Colorado-specific data. And we know that having receipt of WIC, women, infants, and children, is actually a protective factor. We know that when families receive economic and concrete supports, that is a protective factor. We know that this population experiences almost a triple of the rate of low birth weight compared to the general population. And yet, if this family receives no support and no prenatal care, you cannot affect that statistic at birth. It's already a done deal. And so what I think is one of the biggest challenges is how we move plans of safe care upstream prenatally so that we have an opportunity to capitalize on pregnancy as a very well-documented transformative period for behavioral change when the right supports are in the right place at the right time. And so that's the challenge that I think we're really struggling with here in Colorado and that this pilot is helping to address. I'm going to kick it next to Katrina for any challenges that you think are getting in the way of using plans of safe care to serve families better.
So the challenges that we have ran into is people voluntarily wanting the plans of safe care. They don't want to see it. They feel like they're being stigmatized, biased, or that they're just in fear. Like I said earlier, they don't want to have to write down a plan and have to go through that check mark and then another check mark with somebody else and then another check mark with somebody else. So that is one thing that I've noticed that's kind of the biggest challenge, is having families actually wanting to voluntarily do it.
Thank you, Katrina. I'm skipping Jade and we're going over to Zoom. Jade will close us out on these questions. So Audrey or Dr. Robertson, I cannot talk today, you all. Please take it away.
I think from a provider standpoint, there are lots of different barriers. As we all know, the healthcare industry has been hit very hard since COVID. And so the number of personnel that's available for these individuals to navigate and to reach out to is quite limited, particularly in a rural area. Most of us wear multiple different hats in our organization. From doing this work for 10 years now in the Valley, we see a lot of stigma with these individuals just not wanting to even come into prenatal care, into our clinic waiting room, because they don't think that they belong, and that people are judging them without even knowing what is going on, thinking they're getting judgment as soon as they walk in, even though there is no, from the healthcare perspective and the personnel perspective, or they'll even think that other women within the waiting room are judging them. And then honestly, the schedule within the providers is fairly limited to handle some of the need that these individuals have, and we don't have as much flexibility as this population often needs. And then particularly for women, if their partner continues to use, then we only have so much pull as well. So even though pregnancy is an incredibly motivating time, it depends on the support that they have within them and their own families as well.
Thank you. Anything to add?
Yeah, I'd just like to add the administrative burdens or challenges that can come with this program. But backing up just a moment, in an ideal world, having resources available to help families develop plans of safe care would fall within that sort of population health strategy, or an ability to minimize and address barriers for social determinants of health. And so at San Luis Valley Health, we've been implementing care coordination for quite some time as a defined role on the team, looking at that team-based care model and having folks working at top of scope to really unburden our providers with some of the non-medical tasks, while supporting the care team in alleviating barriers to care. And so when this works well, this role fits nicely within that defined care team member to support. I think where we can struggle certainly around resources to support team members in this capacity. As Dr. Robertson mentioned, we are facing a workforce shortage, and so that's a very real challenge, I'm sure, not just for rural Colorado, but I'm sure across our state. Within that workforce, finding folks who have the skill set unique to support this population. And then I think it goes without saying, and I also think it was mentioned previously, but making sure that this is a living, breathing tool that feels alive and supportive, and patient-centered, and not, as we mentioned, regulatory or sort of a check. We don't want to just check the box that we did it, but we want it to ensure that it's something that took time and critical thinking to create, to be meaningful, so that the patient doesn't feel like they're just a number or just checking boxes or moving through a system, but something that's actually going to provide real value to them. And so having the workforce that's able to do that in a meaningful way can sometimes be difficult to achieve.
Thank you. Jade, round us
I'll
up.
add a couple things. Very concretely, I think the name is the challenge. We've talked about that a lot. We talked about that a lot when we were in the Valley. You know, a plan of safe care sounds a whole lot like a safety plan. It doesn't sound like a plan that I'm driving for my family. It sounds like something that someone else is telling me I have to do. And I think that that's a challenge. I think there are a lot of systemic challenges as well in terms of how and like systemic, but also practical challenges in terms of how, if we want this to be family driven, if we want this to be family owned, how do we do that? How do we set this up? In which system creates this? How do we create an approach where, you know, as a pregnant person with a substance use disorder, I can create this plan and I can do it voluntarily and I can own it and I can take it with me and I can feel confident that when I share it with my provider or with my healthcare provider or my treatment provider or God forbid, child welfare, it is my plan and I own it and I can choose when to share it and I can choose what goes in it and I can drive it for my family and my well-being. But how? How do we do that? How do we bust through the fear and stigma? How do we bust through the systemic challenges and actually connect with these families from a heart space about this journey that they are on and the support that is available in their communities? And I think that that's where we've just gotten really stuck is this a child welfare plan? Does the healthcare provider have to do this? Do we need a community-based organization? Is it a family's plan? And I think it's at some point we're just kind of stuck in that systemic loop of like, well, who's ultimately responsible for this? And where does that even live? In a way that has kind of prevented us from being able to get into the core of why this is important and how are we going to do it.
Thank you. So these are some of the really very real challenges facing folks day in and day out. And I would really underscore three things that the panel said. The first is the fear and the stigma. It can't always be a who, maybe who's plural, that are helping to own these plans of safe care and provide care navigation, because the same person that's trusted for one individual and family might not be the same person that's trusted for another. We also have a real workforce challenge, as was highlighted. And so we can't just assume that in every community, we're going to have this kind of position, do it, it's going to be fine. They can never go on vacation. They certainly can't go on parental leave. And they most definitely need to be on call 24/7, right? That is not realistic. And so we need to think about multiple entry points. We need to be thinking about what works and what are the strengths of local communities to make this happen. So this really brings us then to the problems of practice, right? My interlude of the why. If we want to make sure we're driving change, we don't just focus on the what, we have the interludes of the why. The why. The evidence is more than substantive in this regards, that coordination is essential to improve support and help families not just survive, but thrive. How do we not just talk about the absence of the bad, as in no child welfare involvement, but the presence of the good, right? The strengths that families inherently have and are bringing forth. And plans of safe care can be this lever, but we need that different approach to address these problems of practice the panel has highlighted, from needs to be a living document, reach families earlier with trusted supports, moving from gotcha moments to true, genuine, authentic opportunity for wraparound care, addressing the social determinants of health that was mentioned, those root causes, better making connections and breaking down silos, and ultimately sharing in the responsibility of caring for these families. Moment of vulnerability. It is hard when any one system, be it child welfare or healthcare providers or a community organization, to feel like they have to own the responsibility for plans of safe care. Because that means when it doesn't work, if it's not meeting goals, then it's a I have failed. I have failed families. Versus we as a collective have failed. And we as a collective can succeed, but only if we lean into a co-ownership model and a co-responsibility model. So this is really where we're grounding then in the opportunity to approach plans of safe care differently. This is going to get us into the how. I'm going to turn it back over to Jade to say, wow, now that we've outlined all the problems and you're feeling slightly like, really, y'all? Thanks. Let's give you some hope. Jade?
All right. So we are very, very grateful for the support of the department or the Division of Child Welfare, the Department of Human Services, to give us the funding to really see if we were going to do this different, what would we do different and where would we start? And let's try it. So what we have been creating through this plan of safe care framework and pilot is a new and different approach. So first of all, I want to start by saying, what is a framework? So this probably took us the first year of the pilot, was to agree and figure out on what is a framework. It is not a model. It is not a program. It is not like an evidence-based thing that's being implemented. It is a structure. It is essential elements. It is a data-informed strategic framework for coordinated implementation. And so really what we're attempting to do is create this strategic container that really will allow us to align and coordinate on the ground. So there are essential elements. There are data-driven components that we're going to be measuring fidelity to, but we're not taking an existing program or model and trying to implement that. We're saying in any community, and that's really what we're testing, is this framework. In any community, can we take this framework and identify the moving pieces, the parts and players, the essential elements, and plug those in, and will it work the same? So we're starting in the San Luis Valley, and we are grateful for our partners, and we'll share a little bit about some of the funding that made this possible as well. But really, it's about trying to get to this long-term hopes that we've identified, that we can establish plans of safe care as a mechanism to really support families on their recovery journey. So what are we doing? So those essential elements I mentioned. So we started with 4 guiding features. Prenatal initiation. As you heard, when we get to that kind of birth hospitalization moment, there are a lot of things that are already in progress. We've already had some of our, low birth weight or our other things have already been impacted. It's a very vulnerable time around child welfare involvement. Kind of in a lot of ways, birth hospitalization is too late to initiate your plan of safe care. And so our first guiding feature is of this framework of what we're going to try and do different is initiate as soon as possible. So prenatally, ideally, but as soon as possible to really start this process early as possible. Voluntary engagement. I know Katrina mentioned this earlier. It is one of the challenges. It's part of the stigma. It's part of the issue with the name. But we are really looking for, through this pilot, the plan of safe care to be something that families are choosing to engage in, that they have trust that when they create this plan, that this plan is actually going to be protective. It's going to help them get on their journey with treatment or recovery support or whatever that looks like. It's going to be empowering them in the decisions that they are making for themselves and their child and their life. It is not something that someone is coming in and saying, you have to do this. Now, we understand that families involved with child welfare, that is not going to be a possibility, right? That has, child welfare, because of federal law, has to make sure a plan of safe care is in place. So we know that it's not always going to be able to be voluntary. But what we're focused on is how can we create as many as possible voluntarily, prenatally, so that by the time it gets to child welfare, there are very few that need to come in from that involuntary approach. And that more often than not, families are going in and saying, here's my plan of safe care. You can just approve that I have one, and we can move on. Number 3, comprehensive service delivery and tracking. Really what we're focused on here is how do we know that this is working? How do we know that we're able to do the care coordination components of this? How are we able to understand that, families are able to move from those multiple different ways that they might come in? I think acuity of need is a big component of this, and knowing that we might have some families that need a plan of safe care because of their methadone And so we know that they've already been involved in treatment, but they're still going to have an infant that tests positive at birth. So let's get that plan of safe care in place. That's a really different acuity need for a family than someone who has been kind of using substances throughout their entire pregnancy without any treatment or other support. And so we need to be able to have a very comprehensive service array to be able to connect families to whatever is most supportive for them based on where they're at in their journey or where they're at in their level of need and interest. Finally, this has to be cross-system. This has to be collaborative. We have to be on the same page. You've heard it already today many, many times about our silos. This is about the infrastructure that we're putting in place across communities in this community to be able to have kind of shared training, shared language, shared data systems, agreements around releases of information so that we have this infrastructure that can be collaborative across. The perinatal continuum is another thing I'll just touch on. And so you heard Courtney mention multiple entry points. We're going to talk about that a lot. But when we designed this pilot, we felt like it was really important to talk about what does it look like prenatally. You have families that can come in from multiple different places, no child welfare involvement unless there's older children, and then varying levels of need and acuity, as I mentioned. You have the birthplace where it's really hospital is the primary entry point, possibility for child welfare involvement, again, varying levels of acuity. And then finally, postnatally, same idea, multiple entry points, possible child welfare involvement, varying levels of acuity. But we wanted this framework to be able to cross all of this because we know that for families, this is real. We can't just kind of focus on one of these points because we'll miss opportunities in the others. So the major activities or the major components of this framework are twofold. One is activation pathways. So what happens? What are those pathways? What happens when we identify a family that is in need of a plan of safe care that meets those requirements? How do we make sure there are really clean, easy pathways to initiate that plan of safe care, to get them connected to resources and supports that are ultimately going to achieve that care coordination outcome? The second component of this is our aligned infrastructure. And so as we mentioned, that's about the data sharing, that's about our releases and our agreements, that's about making sure that we have structures that can ensure across this catchment area, across systems, that we're able to respond to and connect with families quickly. So here's an example of what we're actually talking about. So top left, identification or disclosure of substance use in the perinatal period. That's step one. That could happen through screening at a prenatal appointment. That could happen through identification at the Sharps clinic of pregnancy. That could happen through, any other interface, WIC, etc., where a family might identify substance use or a trusted professional might identify kind of the presence of both. Step one, plan of safe care is offered as a support voluntarily. Again, this is going to be a big linchpin for us, right? Is whether or not we can bust enough stigma in the community that when that plan of safe care is offered, the family is willing to engage in it. Step three here, plan of safe care is initiated, needs assessment occurs. Step 4, plan of safe care is developed. Plan of safe care is activated, step 5, and then referral and care coordination and follow-up. All of this really being supported by the backbone care coordination and learning and improvement infrastructure underneath it. It looks kind of simple here, and I'm going to skip to this one real quick. And this is what it looks like in practice. So our entry points, top right, entry points, and at the very top, these are all of the different places where families could come into contact with a trusted professional who can help initiate the plan of safe care. This middle box, AHEC, for example, is where we're looking in our pilot of having our senior specialized providers. Those are going to be the folks that can actually create and develop that plan of safe care. So the idea is anyone can initiate. A family can self-initiate, but it's really around these specialized providers that do that development of the plan of safe care hand in hand with the family. Right now, it's primarily our community partners at AHEC, and Katrina can share more about what that looks like. But also knowing that, There are many other places down here. We have other entry points through the hospital, through our substance use treatment providers or our other medical providers in the community, our behavioral health group. All of these will have access to different components to be able to cross-check and coordinate and work together on that aligned infrastructure so that regardless of where a family comes in, they have the ability to work with someone they know and trust to create that plan of safe care, to get connected to community-based organizations and providers, and to be able to move forward how they want to in partnership with whatever provider they feel most connected to in their community. And you'll see here, it's about warm handoffs. It's about, yes, it is family owned, but there's also someone in the system that is charged with it, that is charged with supporting plans of safe care, with making sure they get done, with following up and providing outreach, but that the family is the one who really gets to own this. And ideally, this is all prenatal. This is all initiating prenatally so that by the time you're reaching birth hospitalization, it is a, yep, we have that in place. Let's, add a few details and support this family at this point in their journey. I wanted to go back to this one because this is what has allowed us to do this. And so this is a HRSA grant, Health Resources Services Administration. This is round 2 of our HRSA grant. Audrey mentioned it. These green boxes, which you probably can't read, are the primary drivers, the thing we're focused on. The first one is increased access to coordinated preconception services. Second one is increased access to coordinated prenatal labor and delivery and behavioral health services. And the last one is coordinated access to postpartum services. And so these are the 3 things that we're able to fund with this grant, which is what has allowed us to be able to do this in the San Luis Valley, is that we are able to fund actual positions that can do this kind of work on the ground in the community. And I believe with that, okay, so this is, the last point is coming back to this notification thing. So I highlighted earlier, I previewed earlier, healthcare providers are required to notify Child Protective Services of the occurrence of an infant with prenatal substance exposure. There is, that's a pretty, it's a pretty vague statement. What does it mean that I have to notify you? Again, in Colorado, since we don't have a process, what that means is you have to report. And we've changed Colorado's law so that what you have to report, our mandatory reporting laws, are much more focused on the impact of the infants. But then how do we right size that federal law says you must notify, but you don't have to report if it doesn't meet state law? That is the final component of this pilot that we're trying to figure out, is what is that infrastructure that is necessary to separate those 2 processes, and how can we do that? And so that's what we're going to be testing as well, is kind of what is the distinction between a plan of safe care notification, so notifying child welfare in some way, shape, or form that you had a prenatally exposed infant that you created a plan of safe care for, potentially even de-identified or anonymously. And how does that differentiate from a child welfare mandatory report? Because those are 2 very different things. We're also looking at this as potentially an opportunity to be initiating plans of safe care later if by chance we're identifying folks who did meet that requirement, who were eligible for a plan of safe care or in need of a plan of safe care and had not gotten one. How do we use a different approach from this notification pathway to say, oh, we missed one, let's reach out to this family and offer them support? And then how do we actually do accurate data collection and reporting? Because at the end of the day, the statistics that Courtney shared, the 39% of infants that actually have a plan of safe care, that's of child welfare involved infants. We don't actually know what that looks like on a much broader scale than that. So I think I will turn it back over to Courtney for our next panel question.
Thank you, Jade. And before we do, I have to go back to this graphic really quick because I do want to underscore something that I heard a lot in the workshops. By the way, I really like having the workshops first. That was really fun. Because I think it got us right into the concrete level of what does this actually look like in practice, right? And one of the things that came up, I felt like and heard over and over again in this space and others is, as a provider, depending on your role, it's often not necessarily you as the individual who has the time or capacity to actually fully develop out the plan of safe care, to figure out should I or should I not report to child welfare and all that good stuff. And many of you are like, that's why I have a care team, right? That's why I have a social worker on staff. That's why I have a behavioral health therapist on staff that helps me with this. We're really trying to think about what that looks like in really specific ways in this pilot so that the person who identifies the need for a plan of safe care and starts it does not have to be the person who completes a plan of safe care. It does not have to be the person who necessarily provides the care coordination. Because ideally, care coordination is also happening 6 to 12 months after the birth event itself because needs change, right? And so I just want to underscore that in this visual, and our partners at San Luis Valley Health will probably speak to this more, it is important to think about what are the specific positions that are right-sized to actually develop the plan of safe care and do care coordination versus who within the hospital system, for instance, or in prenatal providers are the right ones to initiate, oh, I need one, but here's the handoff, and here's how I know who to go to next for full development. Okay. So with that, I'm now going to take us into how this approach can help us to overcome the challenges or the problems of practice that we kicked off this panel with. I'll once again kick us off and then turn it to Katrina next. So really for me, I am thinking about the opportunity to lean into local level strengths and really not create an add-on and stir moment. Like I think we have a tendency, especially in states like Colorado, you know what we love, you all? We love pilots. Like literally, I have a job because we love to pilot everything, okay? And then we build evidence on it, okay? And that's great, but only if it's being additive in a way that's complementary, not additive in a way that's actually taking away from an ability to align our investments and learn from each other in a very real and authentic manner. And so I'm excited for this because by creating a framework that can be adapted to local communities, you have these essential elements, as Jade spoke to, that can have data behind them. And then you can actually fit them into communities so that we have a model, a blueprint, if you will, to break down those silos, bring in local level strengths and identify local level gaps that we can then bring in practices from other communities that have kind of figured it out a little bit more than maybe we have in another area of the state. So I'm very excited to see the both and there and create that balance of cohesion with flexibility. Katrina, how about you? How do you think this kind of approach can help overcome some of the challenges you noted at the beginning of today?
I think it's going to help a lot by breaking the bias and the stigma and being able to bring communities together instead of separating them and educating the communities and the healthcare providers of how to come with empathy and consideration to those that are needing these services that may not want it or are in fear of it. So I think this is going to be a great approach for it.
Thank you. I'm going to go next to our partners at San Luis Valley Health on Zoom. Audrey or Dr. Robertson, would you like to kick us off?
Sure. So I think this pilot builds on strengths that the San Luis Valley possesses regarding collaboration and community partnership. We have a long history in our community of doing that very well. And I think that this pilot project just enhances a lot of those partnerships in play. I think we're thrilled to be getting to work closely with AHEC on this project, specifically in having a partner in the community so that truly folks who have these needs have a no wrong door approach, so that whether they interact with folks at AHEC out in the community or they come in through our women's health department, or maybe they have not had any connection up till the point of running into some more high needs situations going on, we have resources available in our emergency departments. And then certainly up on labor and delivery at the point of delivery, though, as said multiple times, we really hope to avoid that being our first point of contact in these situations if possible. I think that this framework just takes a lot of those partnerships and the opportunities that we have in play and creates a more formal structure around them so that we know specifically what to provide to not only meet the regulations, which I know is not the ultimate goal, but to truly provide families with something of benefit to support them in their journey. I know that this pilot in particular provides us with some great resources to maximize the roles of our team members to have this additional support made available. And I'm most excited that this allows us to bring on an additional team member in the form of a discharge planner to our labor and delivery team. We've never had that role before, and I think we've gone a long time without it. And having somebody up on the floor with that dedicated role and expertise to either help develop that plan for safe care if it's not been made available yet, be physically able to just go to the various places like the emergency department and meet with folks who might be coming in the door with some of these higher level needs, but then also to connect patients back to the community, like you mentioned, for that ongoing care coordination after delivery, whether that's to AHEC or to another community partner. I think it's a huge win that we will be able to achieve with this additional role that we're hoping to bring on.
Thank you. Dr. Robertson.
I think you mentioned it already. It really does build on existing efforts. This area is fairly isolated, and we know that it's underserved in many different aspects. And so providers here have been knowing and seeing substance use for a long time, and we feel this more acutely when we're the ones called in the middle of the night to do a cesarean delivery because a baby's not doing well after a mom used substances, thinking that would help her with her labor pains. And so about 9 or so years ago, it started with one provider having a lot of courage to start substance use treatment de novo here in our area, and then just ballooned. And so actually, because of our efforts through this grant and through the just monetary support for our care coordination, we now, as the OB providers, are the top group in our organization that provides substance use treatment along with OB care. And it's mainly because we've been able to have a care coordinator specifically to address all these issues. And if a provider is not supported with the behavioral social piece of it, then the provider will often burn out and then stop using or stop assisting with substance use treatment. So it's been really wonderful that the providers have latched on to this. We don't have really a silo of an addiction clinic that all the patients go to that one group. We do have an addiction provider who's fellowship trained in our area who provides support, but it's actually, for example, the OB providers that are leading the charge for subcutaneous Suboxone or buprenorphine in our area. So it's really kind of neat because of this approach and really the support that it gives us. Then we can really start attacking the medical needs of these patients. And then we have the trust from the community. Our providers have been here for a number of years. And in this community, when the word gets out that they will not be, sent over to disciplinary action, when they mention that they use substance and they're pregnant, they come and they bring family members or friends, and we can really buy in so that we can improve the overall health of our community.
Thank you so much. Jade.
I'll just add one quick thing, which is I think we've struggled with plans of safe care in Colorado for a very long time. And I think that this pilot is going to give us the chance to do some more clear, documented learning and really create a framework that can be successful outside of just the Valley. And we are so grateful for our partners there.
Thank you. So in our last 5 minutes, I want to kind of bring everything you've heard together and transfer it back to the local level learnings I hope you leave this room with today. So we really are trying to hit the kind of piece of both a systems level aspect with infrastructure. That's what you really heard about through the framework, those essential components. And we need to figure out the local level piece of implementation, right? And to do this, one of the things that I'm really hoping you'll walk away with is what within the framework can you utilize to tomorrow, quite literally tomorrow, that you can start to map your work onto, and what are your local level implementation and activation pathways, right? What's going well about them? Where have you been inspired from not just this talk, but all the talks today to do things differently, to tweak it? Sometimes it's a tweak, right? Sometimes it's not a whole new lane. It's not a whole new something. It's a tweak. It's a pivot, right? Keeping the vision constant of family-owned and family-created voluntary plans of safe care, but letting strategy pivot when necessary to meet that vision. And together, I think this idea of a systems level and local level viewpoints, what's going to ultimately drive out our outcomes, reduce our inefficiencies, of which from a data perspective, I'm here to tell you there are some. And so how do we do that and promote that co-ownership? And it leads us in our last couple of minutes to returning to the shared why. I know that the question is posed as a what question of what are your hopes for the plan of safe care pilot, but it is meant to be returning to the why. Why are we doing this? Why are we approaching it differently? So I'm going to kick us off around really, what are your hopes, panel? In 4 or 5 years from now, when we go and we're hopefully back talking with you all about the successes of this, what do you hope what we're going to say? And this time I'm going to go in a bit of a reverse order. I'm actually going to kick it over to our local level partners back on the Zoom first, San Luis Valley Health, Dr. Robertson or Audrey. What are your hopes?
Do you want to start, Dr. Robertson, or do you want me to?
Go ahead.
Okay. I think it was very nicely said by Jade before, but I think that it all comes down to, oh no, it's actually Dr. Robertson. So stealing your thunder, Dr. Robertson. But I think it comes down to my personal hope is improved trust. I think healthcare has such an opportunity to be a trusted resource for folks, but I also know that it's also a place that can feel really scary. And so my hope is that through this work, we are able to build trust in our community, that we are a safe place to go for support. And as a result, I hope we see improved outcomes for those that are struggling and that would benefit from the resources that are being provided through this pilot. And then, of course, because of the role that I play, my hope is that we see an overall improved population health outcome and an improved health outcome for our community in addressing those social determinants of health and resources that families need to thrive. And kick it over to Dr. Robertson.
Yeah, I think it's very similar. This is a small community. Our children go to school with a lot of individuals that are having issues with this. And so we will really see it in a day-to-day basis of families that are struggling with substance use. Currently, I mean, I looked at our data real quickly. We've been collecting data through the Chosen Network for 5 years. We have had a precipitous increase since COVID of substance exposed newborns, as I'm sure everybody has, but currently it's at 6 to 7% of our infants that are born have this exposure. And these are high needs infants that require a lot of attention from a staff that are already stretched pretty significantly. So I hope that the sheer number of substance exposed newborns will go down in general, but those that are exposed have a lot more prenatal visits than the ones that we have currently, because even each prenatal visit shows that they have a better healthy newborn at the end of it. We try to keep these newborns here in our area, but if we have to fly them out to our NICU, then that disrupts the family at a very pivotal moment. So I hope that this plan of safe care will provide, again, that support and also take some of the work off of our nurses on our labor and delivery unit that are often stuck, kind of stretched in many different ways.
Thank you. Katrina.
In hopes of this panel, I'm hoping that it also brings down the numbers in the substance use with prenatal care, but also that it brings the community and the healthcare closer together with that trust, and also brings the community education, and it lets them be aware of what is happening and that they are improving the situation and not making the situation worse or more frightening or fearful for those families that are going through this problem or this journey in their life.
I think my greatest hope is that everything we just said actually happens, that we are truly able to establish plans of safe care with a new name as a true family-driven, family-owned pathway or journey towards recovery and well-being and success for their family, and that we are able to do so in a way that is grounded in families, is grounded in community, is grounded in trust and equity, and that this really is a turning point for families towards success and well-being, rather than what I'm afraid it has served to be so far, which is just another kind of slap on the wrist for families, another thing that just continues child welfare involvement and continues, really difficult circumstances.
And I hope to measure all the successes they just outlined for the next several years. But in all seriousness, how will we know when we are successful? I think it's going to be through a combination of numbers and narratives that really start to center outcomes that matter to families and communities, not just our usual outcomes of did you or did you not have a plan of safe care. I want the data to show me that more families had the opportunity for a doula, more families had the opportunity for community health workers and peer navigator support, that more families took advantage of home visiting programs in their local communities. I want the data to show me that that helped divert families from child welfare involvement when it was otherwise not appropriate. And I ultimately hope that it shows us a model that we can use on practice and policy levels to get the resourcing necessary and the coalition of the willing necessary to move this forward on a true systems change level. So with that, I want to thank our funders once again, both from the federal level with HRSA as well as local level with our CDHS Division of Child Welfare, our local implementation partners, Shannon Bryan, special shout out, who continues to be our partner in hope around all things this pilot, the pilot team, and of course, most importantly, the panel that is here to share their wisdom today. Thank you all so much.
Questions or comments. I can get us started. So, I'm real practical,
I love your practical.
So, I'm going to ask you the practical question. So the two things that come to mind is, I know we want it to be family owned, but where does it live? And who makes sure that it exists? And my second question is, who has access to wherever this lives? And then who tracks it over time? Right? Like the data piece. I was going to ask that.
Of course I did. I'm going back to a graphic. Thank you very much for the question. So I'll kick us off and then please others jump in here at how you see it concretely. There's my graphic. So we actually just recently discussed this with Audrey and other partners at San Luis Valley Health as well as at AHEC and really thought about what would it look like to be family owned. So I think there's a couple of components to that. Let's make them concrete and operationalized. One, that means the family should be able to first and foremost initiate their own plan of safe care. They shouldn't have to be waiting for a professional to do it, okay? We'll talk about what that's going to look like in just a second mechanically. Two, they need to be able to have access to the plan of safe care, whomever creates it, right? It's like when I try to access my own patient chart, I'm on the struggle bus all the time, y'all, because I can't remember my password, okay? But I actually do know how to access my patient chart, right? I have the patient portal part of it. How do we give families that same access where plan of safe care becomes a living document? That's the second component of being family owned. The third is the release of information piece that has multiple layers so that if there's all this information, which set of that information gets released to everybody versus maybe which set of that information really, as my fill in the blank pediatrician, this is the set you need to know, right? Versus as my home visitor for Family Connects, this is the piece of information you need to know. So the other innovation that we are aiming to pilot in this pilot, no pun, I told you Colorado, is really around utilizing a social health information exchange platform where you all are familiar, of course, with health information exchange platforms, Epic or whatever it is you use, connecting those to behavioral health and other community records, and really allowing that platform to be where the plan of safe care, the literal plan, lives, and then giving permissions, and this is why I brought up this document, of San Luis Valley Health partners, specifically the positions of care coordinators and the discharge coordinator that was spoken to, our senior specialized providers, having a release of information that the plan of safe care gets entered into that and lives there. So those entities can always check the whole of it. Does it exist? Also, there's nothing better to break trust, you all, than literally asking a family to fill out a plan of safe care 7 times, right? So we've got to figure that piece out too. So really leaning into that innovation. And then thinking about utilizing it for closed loop referrals and to understand like who's tracking it. That's where our senior specialized providers would be providing ongoing care coordination when that relationship is built. When that relationship is built with San Luis Valley Health, then their care coordinators and discharge coordinator would be providing ongoing care coordination up until the time when they leave that care. And if that family needs ongoing care, let's say 6 to 12 months postpartum, then it would transfer over to Katrina and her team at AHEC to carry on that community-based support. Somebody said it earlier really well, by the way, that at the end of the day, we sometimes are really good at connecting folks with professionals and systems, but pretty terrible at connecting them with community. And so this is the idea, is to continue that care coordination with a community-based agency that could help cultivate that. And we are going to utilize the Social Health Information Exchange platform to do exactly that. So we can hit on the points of family-owned and the care coordination piece. We're going to take it slow and steady, wins the race. Fun fact, I have a 22-year-old tortoise at home. He reminds me daily, this is a marathon, not a sprint, y'all. And so we are first and foremost going to look at it as holding the plan of safe care and sort of assisting with some of those referral pieces, but not wanting to put duplicative burden on our healthcare providers. So then thinking about what that interoperability looks like down the road so that the whatever you use, Epic or another one in the case of the Valley, could be directly integrated with that social health information exchange so there isn't duplication of efforts. So that is the goal that we'll be piloting. Does that help? Panel, would you add anything, either Zoom or humans in person? Okay. Additional questions? Hi.
How about now? Thank you. This is incredible. And we are so excited to hear in our community how this goes so that we can learn from it. I think we can all imagine patients for whom a plan of safe care really makes sense, and where, you know, it's definitely a person who for whom this, you know, but has the potential to benefit them. But I'm worried more about these gray areas of who's included, and it's kind of from a data point of view, but also from an equity of, like, you know, if we're making these marginal calls for including people in this group, who are we leaning more to include and less so? And the ideas that I came up with were, you know, does tobacco count? Isolated alcohol early in pregnancy, less stigmatized prescription drugs like gabapentin, the spectrum between gabapentin and benzodiazepines, and which patients are being referred for these services are included here, misuse of prescription medicines, and then, of course, isolated THC. And I'm just wondering how you guys are making the difficult calls about who to include, who to potentially inflict this benefit on, but also put at risk of receiving some of the harms of an intervention like this.
Surveillance, right? Which is also what you're referring to. Yeah, Jade's going to take this one.
All right. So I think the main place I want to start is actually all the way back in our definition. So prenatal substance, I'm actually not going to use this one. Here we go. So federal law says born and identified as affected by prenatal exposure. So I think that's kind of the language that we're leaning into. There is actually a definition in Volume 7, which dictates child welfare rule, that actually defines what does it mean to be affected by prenatal exposure. And we're really talking about like measurable impacts on well-being, on development, et cetera. So this is kind of the language that is the requirement. So a couple of comments here. One is, I think our current approach is for the Valley, for the pilot, substance use, pregnancy, it's an offer and it is voluntary. And so at that point, anyone can say no. By the time you get to kind of delivery, it's still voluntary. The only time that this isn't voluntary is when child welfare is involved. And I think that's the thing that we are kind of continuing to come back to, which is how do we build the structure so that from a healthcare provider perspective, when you have to make this notification, you are very clearly saying, this is a prenatal substance exposure. There is a plan of safe care or there isn't a plan of safe care, period. And if that's what your notification is, that's your notification. And that is a separate process from when you are saying, I am really concerned about this infant and I feel like we need to have child welfare involved because of these health or safety impacts. So really the idea is that kind of up until child welfare involvement, it is fully voluntary for any time we have substance use and we have pregnancy. Families can decline, but once they're involved with child welfare, they no longer can. Now, I understand all of the risks in there that are things like it's going to be used against them if they decline a plan of safe care. We had some really difficult conversations about that when we were in the Valley, and all of that is real. But I think that's why we're trying to push this all the way back upstream to say it is prenatally developed, it is owned by the family, and that therefore, by the time we're really getting farther into this, it's not being used as a tool or a punishment. It is theirs to own. And if they say, I drank alcohol up until 3 months pregnant, I don't see any effects, I'm not currently using substances, this isn't important this isn't something that is meaningful for me, then there shouldn't be a reason to be involved in child welfare. And if child welfare gets involved for a different reason, or if child welfare gets involved for that reason, they might have a different approach. But the work that we're doing in the healthcare system or in the community is really allowing the family to own and drive that decision for themselves. Did anybody else want to add anything to that?
All right. Well, thank you so much for that whirlwind. And we can't wait to have you back in a couple of years to hear about the results, both lived experience, qualitative, as well as the data. Let's take a 10-minute break and we will be back at 2:55.